Thank you very much for inviting me to give this talk on the impact of respiratory monitoring in sedated patients in current practice. Procedural sedation and analgesia is an important patient-related quality issue. Why is it important? Well, for patient experience, we should make sure that the sedation is enough. On the other hand, there is an inherent risk of causing harm to the patient, so it should also be safe. So the topic of this talk is to answer the question whether capnography is necessary to monitor the patient during sedation and can make it procedural sedation safer. If we look at the guidelines that are available, there seems to be some contradiction between the anesthetist and the endoscopy guidelines. The anesthetists strongly recommend that it should be used in all patients undergoing procedural sedation. However, in the first endoscopy guidelines from 2010, you can see that because of the limited clinical impact, it was not recommended as a standard. In the revised guideline from 2015, a suggestion is made that in high-risk patients and for deep sedation and long procedure, when non-anesthetist propofol sedation is given, that it can be used. So on the one hand, we have a strong recommendation to use it in all patients for procedural sedation. And on the other hand, there's a suggestion to only use it in high-risk patients, long procedures, or deep sedation. So when we were confronted, when we were discussing the introduction of this in a hospital, we were a little bit in doubt about this. I think there's also a bit of a misconception about conscious sedation, because this seems to be a contradiction in terms, because sedation as such reduces consciousness, and sometimes it's hard to predict the level. Obviously, you don't want to reach the level of general anesthesia, and you may want to set out to have a level 2 or level 3 sedation. But due to patient-related factors, it can very well be that you will evolve from level 2, level 3 to level 4 during the same procedure, and this will be difficult to predict. So for the development of hospital-wide sedation protocol, capnography was proposed by our anesthetist, but we wondered whether there was really an additional clinical value in terms of safety, because we did not have that perception at least, and we also wondered whether it was worth all the money spent on capnography for this. As I told you before, we were a little bit wondering about this because of the literature on the one side and the guidelines, and some of the pieces of the evidence in the literature are confusing. For instance, this one is a randomized controlled trial showing that the number and duration of hypoxemia is reduced due to capnography, so you detect it earlier, but the clinical impact in this study was quite limited, and therefore they say that it may not be necessary to use this. But note that there were only 270 patients in each of the arms of this study. So in our pilot study, to address this question that we were faced with for introduction for a sedation protocol, we did a before and after quality improvement evaluation, where in the first group we applied standard of care monitoring, and in the second group, after training in sedation and implementation of capnography, we assessed a different group of patients. Note that we only use this for patients undergoing conscious sedation with midazolam and or pethidine in the absence of an anesthetist, because then we always use propofol and capnography is always present. So we calculated that we needed 660 patients to obtain a significant 20% reduction in the total incidence of mild severe oxygen desaturation, bradycardia, and tachycardia, which was the primary endpoint of this observational study. And we wanted also to assess the relation with the type of procedure, the ASA class, and the location. So where did the problems happen? Was it during the procedure in the endoscopy room, or was it in the recovery room? So this is the distribution of the procedures. So we had more than 1,000 procedures in the baseline group and more than 1,000 in the capnography group. The majority were colonoscopies and gastroscopies, followed by bronchoscopies. Looking at the patient risk stratification, the majority of the patients were ASA-1 and ASA-2 level, and we had 10 to 15% of the patients in ASA-3 class. These are the evolutions of the adverse events in this observational study, and you can see that the adverse event incidence decreased by 56% with capnography. So the first part of the study in group 1, we had 11.5% adverse events, and in the second part, only 5%. And we set out to reach 9.70%, so we went far below that with a relative risk of 0.43 after introduction of capnography. Looking at the adverse event, 100 patients receiving standard of care and 54 patients in the capnography arm experienced at least one adverse event. You can see the majority of these adverse events were oxygen desaturation, but also severe oxygen desaturation was significantly reduced after introduction of capnography. If we look at the need for intervention, 68 patients, 6.2% received an intervention in the standard of care group and 41 patients in the capnography group. The majority of these were just application of oxygen and stimulation of the patient, but note that in the capnography group there was no need for reversal agents and no major interventions like CPR was done in the capnography group. Then if we look at the relation to the procedure, you can see that for all the procedures, there was a higher incidence of occurrence of these adverse events before introduction of capnography, and after introduction, this significantly reduced. Also, if we look at orange, the need for intervention, this was significantly lower after introduction of capnography, and this was independent of the procedures. And then if we look at the ASA level of the patient, maybe a little bit to our surprise, but also patients with ASA-1 and ASA-2 levels experience a significant amount of adverse events without the capnography here in the standard of care arm. And actually this was quite comparable to ASA level 3. And you can see again, looking at the blue bars, that this was significantly reduced after introduction of capnography. Again, looking at orange for the need for interventions, all over the different ASA levels, there was a lower need for intervention. So overall, there was a significant reduction in the risk for adverse events for ASA level 1 and 2, and a significant reduction for the need for intervention in ASA level 3. And then interestingly, if we looked at what happened in the endoscopy room or the recovery, actually our perception of the problem was confirmed in that in the endoscopy room itself, not so much difference was noted between capnography and the baseline group. However, the difference was striking for the difference in occurrence of adverse events in the recovery room. You can see here that there was a risk reduction to 0.17 for adverse events in the recovery room after capnography and to 0.15 for the risk of interventions. And then the last question is whether this is cost effective. We did a cost effective analysis based on the costs of the devices and also the cost of a potential escalation of care. And we calculated that we would save about 55 euros per patient if we would introduce capnography as a standard of care in our hospital for procedural sedation. So in conclusion, sedation is an important part of the endoscopic procedure and has a possible life-threatening complications associated with it. And capnography significantly reduces the risk of sedation-related respiratory adverse events and the need for escalation of care. And this was independent of the procedure and the ASA risk level. So I think our real-life data here concur with findings of randomized controlled trials and substantiate the use of capnography during procedural sedation, especially after the procedure during recovery. I think this is really related to the use of sedative drugs with a longer time of action, such as midazolam and pethidine. Thank you very much for your attention, and I would be happy to answer any of your questions.